You have been placed in listen-only mode. If you have any questions during the presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. The slides from this webinar, as well as a recording of the event, will be made available on the provider page of our website by tomorrow afternoon. Additionally, as always, we thank you for your participation in a brief poll that will be issued during the last 5 minutes of today's event. Our presentations today include a discussion about how to build COVID-19 vaccine confidence among providers, staff, and patients, a review of our COVID-19 vaccine information for providers webpage, and recent epidemiology of COVID-19 in New York City. And with that, I will hand it over to Dr. Ray, Critical Care Planning Lead for the agency's outbreak response.
Hello, everyone. And Ali, could you please advance the slide? So as Ali mentioned, we're going to have a really exciting lineup for you today with a lot of information about vaccines. And we have a really abbreviated recent epidemiology of New York City today. Tune in at our next webinar, which I believe will be in 2 weeks, for more in-depth epidemiology at the beginning. And can you advance the slide, please? So our current status of the pandemic worldwide, we are approaching 100 million cases, and we have exceeded 2.2 million deaths. The UK has had the honor of being the highest COVID death rate in the world last week at 16.5 per million. But there are several other countries reporting very high case counts. The US is one of those. So we are at a very sobering moment this week. It is the 1-year anniversary of the first case in the US being reported. Now we are at over 25 million cases and over 400,000 deaths. There, we've noticed over the past couple of weeks increasing cases, especially after the holidays in the U.S. This trend has changed in the last week, where on a 14-day rolling average, we've actually noticed a 16% decrease. Simultaneously, we are rolling out COVID-19 vaccines with over 14 million people who have received at least 1 dose, and over 2 million fully vaccinated. This week also marks a change in our national strategy to controlling the pandemic. They have described this as a wartime strategy with aggressive measures to mitigate and control the transmission of SARS-CoV-2. We will keep you updated on key elements from that in the future. And in New York City, our daily case counts and percent positivity have stabilized. And as many of you are aware, the vaccination campaign is in progress, though our supply remains limited. We'll have an update on that from Dr. Thompson in a moment. And can you advance the slide, please? Many of you have heard in the news and from your patients about emerging SARS-CoV-2 variants. The mutation of SARS-CoV-2 is natural, it's expected, and not surprisingly, there are several new variants of SARS-CoV-2 that have been recently identified. Some of these do appear to be more easily transmitted than circulating strains. One variant in particular, the B.1.1.7 variant, which you may have heard referred to as the UK variant, as it was first detected in the UK, has become dominant there and has been found in multiple US states. There are several cases that have been identified in New York City. About this variant is that it is estimated to be more transmissible than the variants of SARS-CoV-2 we're used to, at approximately 1.5 times more transmissible. However, there is no evidence at the moment that it causes more severe disease, that it can evade detection by our existing diagnostic tests, and whether it can evade natural immunity or vaccine immunity. It is an area of active study. But at the moment, the message from this is that our existing measures, our core 4 measures, are still effective and are perhaps more important than ever on an individual level now. The potential consequences, since individual behaviors should not really change and should just be adhered to more closely, and we should be more rigorous about them on a population level, is that the rapid increase in cases could strain the healthcare system, and that we may actually need higher vaccine coverage than we had previously estimated to control the pandemic and ensure population-level immunity. The implications of this are really that we have to roll out vaccination and mitigation measures as quickly and rigorously as we can, and of course prepare our healthcare system for further surges. And can you advance the slide, please? There are new requirements for air passengers arriving in the United States. As of January 26th, next week, all passengers over the age of 2 arriving in the U.S. from another country have to show at least one of the following: either a negative viral test, both a nucleic acid amplification test and an antigen test are acceptable. However, it must be performed no more than 3 days before the departure of the flight, or documentation of having recovered from COVID-19, including a proof of a positive viral test in the preceding 3 months. And you additionally, to enter the U.S. From a foreign country, need a letter from a healthcare provider or a public health official with clearance to travel. And can you advance the slide, please? Many of you, I know I have heard this question quite a bit, have been asked about the scheduling of administration of a second dose of the vaccine after the first dose is administered. So at the moment, we have 2 vaccines that are available: the Pfizer-BioNTech vaccine, which requires 2 doses 3 weeks or 21 days apart, and the Mrna vaccine, which requires 2 doses 1 month or 28 days apart. So there have been a lot of questions around whether that date range is exact. The CDC issued guidance this morning stating that you should not schedule the second dose earlier than recommended, so at least 21 or 28 days apart. There is a grace period of 4 days. However, the ideal time to administer it would be at least 21 or 28 days, depending on the type of vaccine. If a dose is inadvertently administered earlier than the grace period, it doesn't mandate that the whole series be started again. Similarly, there's guidance around administering the second dose late. These are a little bit more lenient. Again, 21 and 28 days are ideal. However, the vaccines may be administered, and that's both vaccines, up to 6 weeks or 42 days from the first dose. Outside of this dose, so after 42 days, there are limited data available on the efficacy of the vaccine. However, there is scientific reason to believe that the immune response would still be high after this 42-day window. And because of that, if the second dose is administered beyond the 42-day window, there's again no need to restart the vaccine series. And can you advance the slide, please? Finally, around vaccine eligibility, this is determined at the state level. Currently eligible groups include healthcare workers, people ages 65 years and older, all people ages 65 years and older, residents and staff in nursing homes and other group living facilities, and some frontline essential workers such as first responders, teachers and school staff, daycare workers, transit workers, corrections personnel, and grocery store workers. We have a link here, nyc.gov, COVID vaccine distribution. I encourage all of you to check that link frequently as the eligibility rules are changing frequently. And advance the slide, please. And now I'm going to pass off the presentation to Dr. Thompson, who is going to talk about the recent epidemiology of COVID-19 in New York City.
Great, thank you, Dr. A. So hi, everybody. My name is Mrna Thompson. I am one of the co-leads here of the EpiData unit within the Surveillance and Epidemiology branch at the Health Department, and I am going to go over a couple of different key elements of the Epi from recent days. Just to orient you in case you haven't heard one of my talks before, the kind of main tabs of interest are up here, and I'd also like to point out that all of our data on the main 3 pages here are available on GitHub here, so you can click through any one of these folders and find the most up-to-date data, as well as there's quite a lot of documentation here with information and frequently asked questions. So as Dr. Ray mentioned, we have started to see a stabilization. It's a little too soon to tell whether we truly believe that, but we certainly started to see a stabilization after the holidays. I will go down to our epi curves here so you can see the number of confirmed cases by diagnosis date is shown in light blue, the number of probable cases is shown in gray, and the 7-day average is shown in the dark blue line here. And you can see it certainly peaked around the start of the year, and we have seen a recent decline. We're keeping an eye on the turnaround time, so the time it takes from a patient to getting a test in a clinic and when it's reported to us, as longer turnaround times could influence the reported information here in the most recent 7 days. So we do urge caution in interpreting the recent data, but we have started to see a stabilization in cases anyway. Hospitalizations are still increasing here. You can see a rather steady increase, and unfortunately our death counts are also still increasing. If you look at information by borough, we're seeing fairly consistent stabilization by borough as well, so there's not one borough that's more concerning than another at this point in terms of borough level information. I just want to also point out excuse me, this is citywide percent positivity, which is the metric that we look at most frequently. This is PCR data only, but you can see that the dark blue line here is the percent positivity, 7-day average, and we're hovering around 9% again from the beginning of the year, so that's very good news. Another thing I'd like to point out is this is the diagnostic testing. So you can see we've definitely had an increase in the number of people getting tested since after the year. This is likely people returning from the holiday and wanting to get tested after that. So we're at about 69,000 or so PCR tests every day and about 15,000 antigen tests every day. And then the other things that I'd like to point out, so there are 2 areas of kind of increased concern at a sub-borough level that we're worried about. So one of them is South Brooklyn. You can see the darker the red here, the higher the 7-day percent positivity. Particularly Brighton Beach and Coney Island have been high and consistently high for a number of weeks now, and also surrounding areas of South Brooklyn. We're also concerned with Richmond Hill, Ozone Park, South Ozone Park. This area is also very high, so you can see we are at 15%-ish around this area, about 15%. And in South Brooklyn, this is at about 18% positivity, which is certainly much higher than the citywide average. So those 2 areas are what we're keeping an eye on. And just also to point out here that just in case, you can also see that information in a table format that is sortable. You can click on any of the columns and sort, and you can also search for any particular zip code. And then one other thing that I look at consistently is the borough level percent positivity. Just like the case information, you can see here that things have stabilized. So the borough level percent positivity is shown in green, citywide is shown in blue, and then each zip code is shown in the kind of gray lines. And so things have started to stabilize, so we're very thankful for that. The other thing that I want to point out here is we have a new tab with vaccine information, so I'd encourage you to check this. This is updated in the morning every day, and you can see here we have the number of doses delivered, the number of doses administered, so we now are over 500,000 doses, and I'm sure my vaccination colleagues will talk more about that shortly. Just to also point out that we have this as cumulative number of people vaccinated. The first dose is in gray, and the fully fully vaccinated second dose are in blue, and this is cumulative, and we also have the ability to see this information by day as well. So I know that there are lots of vaccine tidbits to share today, so I'll stop there, but I'm happy to take questions in the chat. Thank you.
Good afternoon, everyone. My name is Jen Lau. I'm a senior advisor within the Office of the Commissioner here. I'm going to spend a few minutes, if you don't mind advancing the slide, talking through our COVID-19 vaccine information page for providers. Many of you may already be familiar with this webpage, but for those of you who it's not, it's really our online resource where we like to direct our providers to so they can stay where they can see the most up-to-date information on COVID-19 vaccine. And while this certainly does not represent everything on COVID-19 vaccines, we've tried to do a good job of at least highlighting and curating the most relevant items for you. We've recently redesigned this page, so I actually want to take a few minutes to walk you all through some of those changes. So let me switch over to share my screen. I'll actually take you through the web page here. So you'll have a URL in the slides when you see it later, but it'll look and feel very similar to some of our other web pages. At the top, you'll see the recent news section. We've been adding dates to make sure that you can see really what's new and highlight any of those important items up top. If I scroll down a little bit in this gray box, you'll also see a list of any upcoming webinars. So for example, you can see today's webinar. We'll also post recent materials from previous webinars here as well. And then we've also included some quick links here to some of our other COVID-19 vaccine pages for quick access there. So I scroll down the page. This is probably the new part for most folks. So we've added some different gray sections, which can expand to view the information within there. So I won't go through all of these sections, and I'll just highlight a couple that might be helpful to start with. So for example, at the top, we have find a vaccination site and make an appointment. Here you'll find links to our other web pages that talk about current eligibility groups. We'll have a link to the vaccine finder, as well as the New York State COVID-19 vaccine form. Close this. Another new section we created is called the Vaccine Communication and Encouragement section. This section is really to help support you talking to both your healthcare staff to build confidence in the vaccine, you can see here, as well as supporting conversations with your patients about answering any of the questions and concerns they might have. You'll also find in this section information for patients. So all the resources listed in this bottom portion are really geared towards a non-clinical audience. So these might be web pages, for example, for FAQs or frequently asked questions. You might also find PDFs or handouts that you can print out and provide to your patients. Another section that you might want to start with on this page is the Storage and Administration section, which you can expand here. And it includes things like the fact sheets for the respective mRNA vaccines, additional patient handouts that you can provide after the vaccine. And then you can see here it has resources for pre-vaccination screening, safety information about the observation period after the vaccine, as well as some links to facilitate reporting on the vaccine. As I scroll down here, we also have the trainings and webinars section. Here we will post past agency presentations as well as presentations from the CDC. And the webinar today, I'll just point out, will also live here, so you can find slides and the recording for today's webinar also in this section. I'll also point out, I know there might be some clinicians and staff from pharmacies and nursing homes, so those are two sections here as well. We are building these sections out, but we'll provide additional targeted resources for you as well. And before I end, let me just share a couple quick tips for this web page. Many of you probably have done this, but you can see here, I've actually bookmarked this page, so I have quick access to this on my internet browser. So you can do this when you get back to your computers, for example. You can see here there are these buttons, expand all and collapse all. If you want to see everything, you can click expand all. And the reason why I'm showing you this is that you can use the find button. So on the keyboard, hit Control and F to bring up an in-page search. So for example, if you know you are looking for a particular resource, you can just type it in here. For example, maybe New York State guidance document. Oops. Of course, it's not working. But you could have seen before I had this in here, but I'll bring you to this document here. So you can use the search feature to quickly find a document if you know it's in here, but maybe you can't remember which section it's in. So those are some of the tips on navigating this page. We are open to feedback on organization and making sure we have the most relevant information. So I can include my email in the chat if you want to send me some of your comments. But that will be, I'll end there for my presentation, and I will now pass it over to my colleague, Dr. Jennifer Rosen.
Great, thank you. So I'll be talking about COVID-19 vaccination, building vaccine confidence among providers, staff, and patients. Next slide. During the presentation, I'll define vaccine hesitancy and provide strategies for moving from hesitancy to vaccine confidence, including strategies for being informed to build trust and building vaccine confidence both among healthcare personnel and patients. Next slide. Vaccine hesitancy is a delay in the acceptance or refusal of vaccines despite the availability of vaccination services. And vaccine hesitancy is complex and context-specific, varying across time, place, and vaccine type. This is a new pandemic, and there are new vaccines, and hesitancy is a normal, rational response, particularly for communities of color that have faced historic and persistent systemic racial oppression. Next slide. Several factors contribute to vaccine hesitancy, including complacency, so for example, low perceived risk of disease. It also includes real and perceived barriers related to lack of accessibility or availability of vaccines, and lack of confidence, including concerns around vaccine safety or effectiveness, the lack of a strong recommendation from a provider, low trust in delivery systems or health authorities, and distrust of governments and pharmaceutical companies. Next slide. Several factors influence decisions about vaccination. This includes contextual factors, for example, media, local politics, religion, culture, and trust in authorities. There are also individual and group influences, including beliefs and attitudes about health and disease prevention, knowledge and awareness about vaccines, and the quality of people's health service experiences. And of course, there are vaccine-specific issues, which I'll talk about more later. Next slide. Vaccine hesitancy occurs among healthcare providers. As an example, in a survey of nurses in the fall, only 34% reported that they would voluntarily receive the COVID vaccine, and only about half felt comfortable discussing the vaccines with their patients. And in a CDC web survey of healthcare providers in the fall, only 63% said that they would get a COVID vaccine. Bear in mind that these surveys were conducted in the fall before vaccines were approved and before data was released on vaccine safety and efficacy. Next slide. Now I'll present some findings from the most recent New York City Health Opinion Poll conducted in December with over 1,000 respondents. And when asked whether people would get vaccinated when a coronavirus vaccine became available to them, only about half said that they would get the vaccine. An additional 26% said they didn't know or weren't sure, and 19% said no. Next slide. Among respondents who said that they would not get vaccinated or who were unsure, the most commonly reported reasons for uncertainty included that they were waiting to learn more about the vaccine before deciding, or that they were worried about the vaccine being developed too quickly. Next slide. Among those who said that they did not intend to or weren't sure if they would get the COVID vaccine, their doctor or pharmacist was the person they most often said they would need to hear from in order to make them feel comfortable receiving it. Next slide. No single strategy can address all the different dimensions of hesitancy. What healthcare providers say and how they interact with the patient and caregiver can strongly influence vaccine acceptance. And so during this presentation, I'll be talking about a Vaccinate with Confidence framework and the focus on evidence-informed best practices to increase vaccine acceptance through skilled conversations about vaccination. Next slide. Vaccine confidence is the trust that patients or providers have in recommended vaccines, the providers who administer vaccines, and processes and policies that lead to vaccine development, licensure, manufacturing, and recommendations for use. People need to have trust in all three to feel fully confident in their decision to get vaccinated. And the foundation of trust is critical and builds over time. This is especially true with patient populations that may have long-standing mistrust of the medical community and government due to historical and continued mistreatment of people of color, immigrants, and people involved in the criminal justice system. Next slide. As part of the framework to vaccinate with confidence, I'll be talking about being informed to build trust, building vaccine confidence among healthcare providers, and building vaccine confidence among patients. Next slide. So we'll start with being informed to build trust. It is really important for providers to have a good understanding of vaccines so that they can provide clear and accurate messages to their patients in a way that's easily understandable. And so for the next several slides, I'll be presenting information that we want everybody to know. Next slide. I'm going to start with vaccine clinical trials because we know that concerns about safety are very commonly reported. So starting with vaccine clinical trials, there are 4 phases of trials, and each phase studies whether vaccines work and are safe. In phase 1 trials, a small number of people are included, typically fewer than 100, and then phase 2 studies include several hundred people. Phase 3 trials are then expanded to include thousands of people, and typically in these phase 3 trials, people either receive vaccine or no vaccine or placebo. And in some cases, phase 4 studies are conducted after vaccine approval, which are studies to continue monitoring the safety and effectiveness of a vaccine after it is available to the public. Next slide. For vaccines, the FDA monitors vaccine development from beginning to end, and they analyze clinical trial data to decide whether to allow the vaccine to be used. And the FDA continues to monitor vaccine safety data even after vaccine approval. Next slide. In an emergency, the FDA may allow vaccines to be used before they are officially licensed by issuing an emergency use authorization, or EUA, so that the vaccines can be used right away. An EUA can be issued only if the evidence strongly suggests that the benefits outweigh any risk to patients. Next slide. Federal agencies and external organizations monitor vaccine safety during during the clinical trials and also after vaccine approval through multiple robust safety systems. Next slide. Many people expressed concern about how quickly the COVID vaccines were developed and questioned how the vaccines could be safe when the process was so quick. And so here's how this happened. We were not starting from scratch. Scientists built on many years of research from other vaccines, including research on vaccines for other coronaviruses. The federal government provided billions of dollars to allow development, testing, and production to happen at the same time. So companies actually started manufacturing the vaccines before the EUA was issued so that they would be ready to distribute them if and when an EUA was issued. And this would never normally happen under normal circumstances because it's incredibly expensive to produce vaccine. And so many vaccines never make it to the approval stage. They never actually get approved. And so companies would never normally produce vaccine without having that approval in place. As well, the federal government, health departments, and healthcare providers like all of you have been working for months to plan for storage, distribution, supplies, and other logistics so that we could hit the ground running as soon as the vaccine was available. Next slide. As everyone knows, 2 vaccines have been authorized by the FDA for use, including the Pfizer and Mrna mRNA vaccines, and other vaccines are in various stages of testing. Next slide. I'm going to give some background about what mRNA vaccines are. There are lots of questions about this. So COVID-19 messenger RNA or mRNA vaccines contain genetic material from the SARS-CoV-2 virus. mRNA vaccines do not contain the actual virus and cannot cause COVID infection. Although the mRNA is a new type of vaccine, it's actually been studied for over 30 years. So again, we weren't starting from scratch. And here's how they work. So the mRNA enters the body with instructions on how to make a protein that is part of the virus that causes COVID-19. The proteins that are produced trigger the body to make antibodies and other immune defenses. The mRNA never enters the nucleus of the cell and never interacts with the person's own DNA. The mRNA is then broken down and destroyed by the body. It does not stay in the body. And then if a person is later exposed to COVID-19, the body is now able to recognize the virus and produce antibodies to fight it. Next slide. COVID-19 mRNA vaccines will not give you COVID-19. None of the COVID vaccines in use or under development use the live virus that causes COVID-19. Patients need to know in advance that they may experience side effects after vaccination, which are normal and expected. This includes things like fever, headache, fatigue, myalgia, and these side effects are signs that the body is building immunity, and the body is responding to the vaccine, and that's a good thing. People also need to know that it takes 1 to 2 weeks after the second dose is received in order to have optimal protection from the vaccine. And so until that time has passed, a person could be exposed to the virus that causes COVID-19 just before or just after vaccination and still get sick from COVID because their body had not yet had enough time after vaccination to make antibodies to provide protection. People also have been asking whether the vaccines will cause them to test positive for COVID, and the answer is no. The authorized vaccines will not cause you to test positive on the viral tests like PCR or antigen testing, which are used for diagnostic purposes to see if you have a current infection. Next slide. Now, in terms of the 2 approved mRNA vaccines, they both have incredibly high overall vaccine efficacy based on the clinical trial, so 94% and higher. And for frame of reference, the FDA only requires that vaccine efficacy be 50% or higher for approval. So this is really remarkable, and incredible news to have such an effective vaccine. The phase 3 study populations were huge for both trials. They each had over 30,000 study volunteers, and importantly, 30% or more of the participants were from communities of color. High efficacy was consistent across age, gender, race, and ethnicity. And safety data were collected for about 8 weeks after people received the second dose in the trials. And it's unusual for side effects to appear more than 8 weeks after vaccination. And during the clinical trials, no serious safety concerns were found for either vaccine. Next slide. Many people are wondering which vaccine they should get, and the reality is the vaccines are much more similar than they are different. They are both mRNA vaccines, both have incredibly high protection against symptoms of COVID-19, both require 2 doses, and both can cause mild to moderate side effects. The main differences are that Pfizer vaccine was authorized for people aged 16 and older versus Mrna for people aged 18 years and older. And the Pfizer vaccine needs to be stored at much lower temperatures and need to be used much more quickly once thawed, which may impact where it's available. Next slide. Vaccination is a much safer way to build protection. The risk of severe illness and death from COVID infection far outweighs any benefits from natural immunity from infection. And the vaccine will help protect you by creating an antibody response without the risk of severe illness. Next slide. Okay, so now we'll talk about building vaccine confidence among healthcare providers. Next slide. At your facility, encourage senior leaders to be vaccine champions. So talk to your leaders about vaccine confidence and ask them to lead by example. So if they've been vaccinated, they could consider being photographed while getting the vaccine, and invite them to share their personal reasons for getting vaccinated. And they can share this informally during conversations with colleagues, at meetings, and at staff presentations, or more formally through things like short videos or social media. Next slide. Host discussions with staff at all different levels. Provide a forum for questions and generate ideas from staff for how to increase vaccine confidence. Include staff representing management, healthcare teams, labor unions, and support staff. And choose a person to facilitate who is a person who's well respected and seen as a neutral convener on the topic. CDC has a discussion guide, which is very useful, that you can find online for more resources. Next slide. Educate your staff about COVID vaccines, how they're developed, how they're monitored for safety, and educate them on how to have effective vaccine conversations and answer common questions. Next slide. It's important to educate both the medical and non-medical staff. Emphasize that the benefits of protecting themselves, their families, their coworkers, and their patients, and importantly, create a feedback mechanism for people to ask questions. And let them know that they also have a very important role to play in making vaccine confidence visible. Next slide. Make the decision to get vaccinated visible. So for example, just like with flu vaccine, provide I got my COVID vaccine stickers or pins or masks, for example. Things that other facilities have reported doing include posting photo galleries in common or break areas of pictures of staff who recently got vaccinated, recording testimonials on why providers in the facility decided to get vaccinated, and reaching out to local news outlets to highlight your facility's leadership in the vaccination process. Next slide. Now we'll talk about building vaccine confidence among patients. Next slide. Even if a patient is not yet eligible to be vaccinated, lay the groundwork for when vaccine becomes available and begin discussing vaccination with them. Let them know now that you recommend the vaccine for them. Provide information on the benefits and safety of vaccination. And if a patient questions your recommendation, this does not necessarily mean that they won't accept it. questions are normal and to be expected. Patients consider their providers to be the most trusted source of information on vaccines, and they may simply want your answers. Next slide. When entering each conversation, start from a place of empathy and understanding. Give your strong recommendation. A provider's recommendation is one of the strongest predictors of vaccine receipt. Make sure that the patient leaves feeling confident in their decision to get vaccinated. And for patients expressing concerns, explore the reasons and motivations. Vaccine safety concerns are very common. Don't just say that vaccines are safe and effective. Provide supporting information. And keep in mind that hesitancy can occur in people across racial, ethnic, and religious groups and is not uniform across any group. Self-assess your own biases and recognize the harms of medical racism on communities of color. Use motivational interviewing, which is an effective tool in producing behavior change in other areas of health. And I'll talk a bit more about that on the next slide. If a patient is uncertain about vaccination, follow up with a guided conversation, starting with asking open-ended questions. So for example, what are your concerns about getting vaccinated? And then reflect and respond to what they've said. Affirm strengths and validate their concerns. So for example, you might say, it's great that you're starting to think about vaccines and your health is important to you. The next step is to ask, provide, and verify. So examples would be, so what do you already know about vaccines? Could I provide you with some information based on what you've just shared? Given our discussion, how do you view things now? And then end with a summary and describe the next steps, the action items. So next slide. Of course, if a person chooses to be vaccinated, vaccinate them and offer praise to affirm their decision. If they're undecided, schedule a new discussion or discuss it at the next visit. So you might say, let's talk about this again once you've had a chance to think more about the vaccination. And then if a person refuses, don't debate it, but leave the door open and let them know that if they change their mind and want to talk about the vaccine, that you're still available. Next slide. Some do's and don'ts. Do take a guiding style. Work with the patient to establish trust. Explore doubts about and interest in vaccination and think from their perspective. Make it known that you're there to listen and reflect on what the patient is saying. Don't take a directive or argumentative style. Don't assume that you understand the patient's reason for concern. Don't argue or debate with the patient. And don't rush through without listening. Next slide. When applying these approaches, always adapt the communication to your setting. Be sensitive to culture, social norms, religion, level of education. And emotions matter when building trust. Account for the feelings and concerns of your patients. Offer them the time, space, and environment for them to digest the information that you've shared and for them to ask questions. Acknowledge and validate their perceptions before you advise them. Be a good listener, be authentic, and show that you care. And always tell the truth, even if that means admitting that you don't know. Guided conversations should take no more time than usual routine interactions and focus on one concern, discussed in a competent and caring manner. And if more time is needed, you can ask them if they can wait, for example, if you're in the process of vaccinating, or book another visit if feasible, or discuss further at their next scheduled appointment. Next slide. And here's a list of some additional resources that are on our webpage. And as mentioned before, this slide set will be posted as well. Thank you.
Thanks, Dr. Rosen. And we have a whole bunch of questions. So I think we'll just get into those right now. And I think the first question is for you, Dr. Rosen. We've had a few questions about the FDA approval process. I know you went over some of what an emergency use authorization or an EUA is, but can you just give us just a quick rundown of the difference between an EUA and a full approval?
Sure. So for full approval, at least 6 months worth of data from the phase 3 trial needs to be included. And for both of these vaccines, the EUA was issued after about 2 months after the second dose. So patients are continuing to be followed for both vaccines so that there's longer-term data. And it is expected that the manufacturing companies will apply for full licensure after it's been at least 6 months.
Great. And we did have a question on how, when they were looking at outcomes of who got COVID and who got severe disease, how were people exposed to COVID and how did that impact the timeline of developing the vaccine?
So I'm not sure I understand the question, but it was a large randomized trial, and matching was done. So the ideal situation is that people all had equal opportunities for exposure in the different groups, if that answers the question.
I think that does. I think that the idea is that they naturally acquired the infection and there wasn't any sort of purposeful exposure. And I think that the point that they may be getting at in the questions were that, with a high background transmission of COVID-19, it's just more likely that people are going to contract it just naturally by existing and going outside. I think, can you talk a little bit about the different populations that the vaccines were tested in?
Sure. So as mentioned, 30% or more of the volunteers in the studies were from people of color, and about more than 20% of people were older adults. So it was very good representation in the studies from diverse populations, which is really important because in the phase 3 trials, you really want the demographics of the population in the study to reflect the demographics of the population that's actually going to be receiving the vaccine.
Thanks, Dr. Rosen. And I just wanted to let our panelists know we don't only have to pick on Dr. Rosen. If any of you would like to comment, you're also welcome to. And I think Dr. Iwamoto, there's a question just about compensation for side effects from the vaccine. I know you provided a link, but can you discuss that and can you just go over what the adverse effects are to the vaccine very quickly?
Hi, this is Martha Iwamoto. Yes, in response to the question about compensation for a severe adverse event, I provided a link to the national information about the National Vaccine Injury Compensation Program, and that describes the program and what the process is. The process begins with an individual filing a petition with the U.S. Court of Federal Claims, and then this website goes into further explanation, which I don't want to spend everyone's time describing that completely here. And I'm sorry, what was the second question? I apologize.
Oh, just an overview of what kind of side effects to expect and how common the adverse effects are.
Okay. Well, so a lot of what we know about the side effects of the vaccines come from the clinical trials, and these were very, very large clinical trials. We know that the vaccines tend to be they are reactogenic, meaning they cause symptoms that many people report, and some of the common symptoms include pain at the injection site, headache, fever, fatigue. We do also know that these side effects are more common after your second dose.
Great, thank you. And I think anyone who wants to answer can go ahead, but there's a question just about patients who are perhaps planning on getting pregnant in the future, in the near future, and maybe what we know about the vaccine and pregnancy.
So I can take that. Pregnant women were not included in the early COVID vaccine studies, but some participants were either pregnant and didn't know it, or they became pregnant during the course of the study. And because of this, we only have a small amount of data regarding safety of these vaccines in pregnant women. The good news is that in this small group of women, no concerns were found and the vaccine worked, but it will be important to get data on larger numbers of women moving forward. That being said, women who are pregnant or planning to get pregnant may choose to get vaccinated, and it is likely to be safe. And if somebody is choosing to get pregnant, they do not need to wait any certain amount of time between getting vaccinated and trying to get pregnant.
And can you, just as a follow-up, talk about any effects the vaccine may have on reproductive health or fertility?
Sure. This is a common question that's come up, and infertility has not been found to be an issue in women infected with COVID-19, so it would not be expected to be a concern for the vaccine. Concerns about antibodies that are made by the vaccine are really unfounded, and these claims they've been circulating online, and they were based on a small number of similar amino acids in two proteins, but the overlap is not sufficient to cause such a reaction like infertility. This is misinformation that has been circulated quite widely.
And I'm going to stick with the adverse effects and side effects. We have a whole host of questions on people having certain conditions, and if that makes it, changes their risk when they take the vaccine, or if they, is a contraindication for the vaccine. So we have autoimmune disease, hypothyroidism is specifically called out here. Then they're also talking about Bell's palsy as a side effect, and people who have, and then are people with severe allergies allowed to take the vaccine, not to the vaccine components itself, but we have penicillin mentioned here, and anybody can take this.
Sure, so I can start in terms of underlying medical conditions. People with underlying medical conditions were included in the studies, not with all medical conditions, but with many of the medical conditions that put people at higher risk for COVID-19. They were included in the study, and people with underlying medical conditions can get the COVID vaccine. A few things to mention: people who there is very limited data on people who are immunocompromised in terms of whether the vaccine is safe or how well someone who's immunocompromised will respond to the vaccine, just because there's very limited data on this either way. People who are immunocompromised, they can still get the vaccine, but providers should counsel them on the limited data that's available. So again, this highlights, because we don't know if the vaccine will work as well in this population, this highlights why it's still so important for people to continue wearing a mask and distancing after they get the vaccine. In terms of Bell's palsy, there were cases of Bell's palsy in the studies, but importantly, the rates of people developing Bell's palsy in the studies was not different from the rate of Bell's palsy occurring in the general population. In terms of can people with allergies to things that are not included, to ingredients that are not included in the vaccine, so for example with penicillin, can they get vaccinated? And the answer is yes. Allergies to food or non-injectable medication or to environmental allergens are not contraindications or precautions to vaccination. And just a reminder for everybody, all patients do need to be monitored after they get the vaccine for at least 15 minutes, and certain people do need to be monitored for 30 minutes, and that includes people who have ever had an anaphylactic reaction to anything. People who have had anaphylactic reactions to, for example, oral antibiotics or to environmental, to food, for example, they should be monitored for 30 minutes after vaccination.
Great, thanks, Dr. Rosen. And then we had a quick question, or we had a few questions just about vaccination in persons who are homebound, and I don't know if anybody has the answer to this. I think one was just the recommendation for people who can't leave their homes to come to a vaccine site. What are we recommending for them? And I think, you know, is it recommended, or should they be prioritized, or should they be seeking out the vaccine at this point?
Sure. So people who are age 65 and older should get the vaccine. So people in this group should get the vaccine. But we are very aware of those concerns and how important it is to be able to get access to vaccine for people in this population. One of the challenges is that the mRNA vaccines are not very stable in terms of the ability to transport them. So, you know, they have special storage requirements, unlike the flu vaccine, which, you know, is easier to, you know, for example, to home nursing services to bring to people's homes. So right now that is challenging, but there are plans in the works to set up services to help get people who are homebound services to go to sites where there is vaccination. So a lot of work is going into improving access to this population.
Great, thank you. And I just want to remind everyone I'm a couple minutes late, but we do have a poll, and I encourage you all to take the poll before the webinar ends. We do use your input from this poll to tailor our future content for this webinar. Let's see, we probably have time for one more question. And just because we have so many questions about side effects and adverse reactions, can you just talk about, you know, how the risk of getting COVID and being sick from COVID stacks up against the risks of the vaccine in different populations?
Sure. I think a really important message is that infection with COVID can be very severe. It obviously can lead to hospitalizations and deaths, as we've seen throughout this pandemic. In terms of vaccine, it is very common to have minimal to moderate side effects after the vaccine. People need to be counseled about this in advance so that they're not surprised. But that includes things that Dr. Iwamoto had mentioned, so things like fatigue, myalgias, redness or soreness at the injection site, headache. You know, these are common, and people might not feel very well for for 1 to 3 days after they get the vaccine. And these symptoms typically go away within 1 to 3 days of starting. So sometimes people are advised to get the vaccine before it begins so that they have time to recover. But these are symptoms that are, again, mild to moderate, and really that pales in comparison to the very serious complications that people can have from COVID infection.
Great, and I know we're at 2 o'clock, but I just wanted to mention, because we've had a lot of different questions alluding to this, what if a person, so when does a person become fully immunized, and after they're fully immunized, can they still transmit the virus, and as a corollary, do they still have to wear their face covering and maintain a physical distance?
Yeah, great question. Optimal protection from the vaccine occurs about 1 to 2 weeks after the second dose is received. We don't know, however, how long protection from the vaccine lasts. And that's because, as I mentioned, the trials that the vaccines received approval after about 2 months after people received the second dose. So longer term follow-up is being done to see, so we know that the vaccine protection lasts at least a few months, but longer term follow-up data is needed to know how long protection will last. And because of that, we don't yet know whether this is something that will require an annual vaccine like the flu shot, or whether people might need a booster shot in future years. So still more to learn. And in terms of the studies were designed to look at how effective the vaccine is at preventing symptomatic infection and serious complications from infection. And we know it works incredibly well against that. There's very limited data to show whether the vaccines protect against asymptomatic infection. So for example, if the virus, if someone breathes in the virus and it's in the nasopharynx, we don't know if the vaccine will prevent that or not. And if not, it's possible that people could still spread the virus even though they themselves don't have any symptoms of COVID. And so that's still something that's being evaluated, and more data will be available in the future. But because of those factors and the fact that no vaccine is 100% effective, it's really important for people to continue to practice the core 4 after they're vaccinated.
All right, thanks, Dr. Rosen. And I think that's all the time we have for questions since we are over time. Just a reminder to everyone, the slides and a recording of this webinar will be available on our provider webpage probably by tomorrow afternoon. And Allison, when is the next one of these webinars scheduled?
Hi, Dr. Ray. Yes, our next webinar is scheduled on Friday, February the 5th, same time, 1 to 2 p.m. We will be updating our provider page with that registration link, and that is the second link you see up on the page in front of you. That's where you can find the slides for this and previous webinars as well. And we will also send out more information via email. So we thank you again for joining us today, and hope you will join us again on February 5th.